Good evening, Dr. Phil here. We will be discussing on raised intracranial pressure in Part 2. Factors that increases intracranial pressure. Mass lesions. Mass lesions increase ICP by increasing the volume of brain substance, bone, and meninges. For brain substance, tumor, infection, hematoma, and pneumocephalus can increase brain substance. Infections such as abscess, hydatid cyst, and encephalitis. Hematoma may be located at subdural, extradural, subarachnoid, intracerebral, and intraventricular locations. It may be due to ruptured intracranial aneurysm, AVM, and trauma. Increased ECF can increase ICP, also known as cerebral edema. Causes of cerebral edema includes trauma, infection, metabolic dysfunction such as hepatic encephalopathy or Rey syndrome, hypoxia, venous obstruction, and increased hydrostatic pressure, such as that caused by steep or prolonged Trendelenburg position on the operating table, high altitude cerebral edema, malignant infarction, and idiopathic. Benign intracranial hypertension is a clinical entity defined by an increase in ICP of more than 15 mm mercury, but which can reach 3 times that figure, in the presence of normal CSF composition, normal conscious level, and no evident pathological processes. Increased CSF volume can increase ICP. CSF is produced at the rate of 0.4 mL per minute. If CSF drainage is blocked or there is an increased CSF production, the increase in intracranial volume causes increased ICP. Examples include congenital and acquired hydrocephalus, which may also be associated with trauma, tumor, or infection, blocked ventricular shunt, and benign intracranial hypertension. Kindly refer to the video on CSF for further details. Increased blood volume can increase ICP. Increased blood volume can be due to increased cerebral blood flow, CBF, or increased cerebral venous volume. Increased CBF can be due to hypoxia, hypercapnia, volatile anesthetic agent, hyperthermia, etc. Increased cerebral venous volume can be due to increased thoracic pressure, venous obstruction in the neck, head down tilt, and coughing. Clinical features of raised intracranial pressure. History to suggest underlying cause, such as history of trauma. Early clinical features include headache. Symptoms are worse in the morning because of increased hydrostatic pressure effects and increased PaCO2 secondary to relative overnight hypoventilation. The headache is worse on coughing and leaning forward. Nausea, vomiting, altered consciousness, which includes drowsiness, listlessness, and irritability or agitation. Seizures, visual disturbances, reduced visual acuity and visual field, focal neurological deficits, and papilloedema. Late signs, Cushing's triad, which includes hypertension, bradycardia, and abnormal respiration such as Keen-Stokes breathing, hyperventilation, and apnea. Cushing's triad is a late and ominous sign that coning is imminent. The carotid body receptors attempt to mediate an increase in cerebral perfusion pressure that is doomed to fail. Altered consciousness, failure of upward gaze, ipsilateral, then bilateral pupillary dilation, decorticate, then decerebrate posturing can occur. Cerebral herniation syndromes. Transcalvarial herniation. Brain matter may herniate out of calvarial defects, such as in post-decompressive hemicraniectomy due to cerebral edema. This can lead to compression of cortical vessels by the bony margins, thereby predisposing to hemorrhagic infarction. Subfalcine or cingulate herniation. The ipsilateral cingulate gyrus of the medial frontal lobe and part of the cerebral hemisphere is forced under the rigid falx cerebri. This is caused by a frontal mass and may be clinically silent. If the anterior cerebral artery is compressed, cerebral infarction of the corresponding motor homunculus can occur. The patient presents with contralateral leg weakness, and abulia, which is lack of decision making, may be present. Central herniation can be descending or ascending. Descending transtentorial herniation, aka coning, increased ICP forces the brain downwards through the foramen magnum as the cerebellar tonsils herniate and compress the medulla. As the brainstem descends, venous congestion along with stretching and tearing of small perforators create Tourette hemorrhages. The patient presents with decorticate then decerebrate posturing through the involvement of rubrospinal and vestibulospinal tracts. Cushing's triad as mentioned, loss of brainstem reflexes, fixed dilated pupils, vegetative state, and death from damage to the respiratory and cardiac centers of the medulla by compression from the herniated cerebellar tonsils through the foramen magnum. Ascending transtentorial herniation. Mass lesions in the posterior cranial fossa may cause superior displacement of superior parts of the cerebellum through the tentorial notch. Compression of the posterior cerebral or superior cerebellar arteries against the tentorium occurs. The patient may present with nausea, vomiting, Perinaud's syndrome, diabetes insipidus, loss of consciousness, and death. Uncal herniation. It is caused by a lateral supratentorial mass. The ipsilateral uncus, which is the inferomedial part of the temporal lobe, it forms the part of the hippocampal gyrus, herniates through the temporal incisura. The uncus is then compressed against the tentorium. The herniated uncus compresses the third cranial nerve against the tentorial edge, causing a constricted followed by a dilated ipsilateral pupil, ophthalmoplegia, motor paralysis of the extraocular muscles, excluding the superior oblique and lateral rectus muscles, which are supplied by the fourth and sixth cranial nerves respectively. A fixed pupil localizes a lesion poorly but is ipsilateralizing. The herniated uncus compresses the cerebral peduncle, causing contralateral hemiparesis. The uncus also compresses the calcarean branch of the posterior cerebral artery, causing infarction within the temporal or occipital lobe. Compression of the ascending reticular activating system in the midbrain results in coma. Further lateral displacement of the brain can cause cerebral aqueduct obstruction resulting in obstructive hydrocephalus, and the Kernohan-Waldman notch phenomenon, which is a false localizing sign where hemiparesis ipsilateral to a mass-occupying lesion occurs. Compression of the contralateral cerebral peduncle against the tentoral edge creates the Kernohan's notch. This damages the contralateral corticospinal tract and causes ipsilateral hemiparesis. Cerebellar tonsil herniation. Increased pressure in the posterior fossa forces the cerebellar tonsils through the foramen magnum. This syndrome may proceed very rapidly given the small size and poor brain compliance at the posterior fossa. The patient presents with ataxia, 6 cranial nerve palsy, upgoing plantar reflexes, loss of consciousness, irregular breathing, and apnea. Life-threatening consequences occur due to compression of the brainstem and upper cervical spinal cord by cerebellar tonsils. Ascending or descending transtentorial herniation usually occurs simultaneously. Ischemia of the brainstem, cerebellar tonsils, and lower cerebellum can occur due to compression of the posterior inferior cerebellar arteries, vertebral arteries and their branches, and origin of the anterior spinal artery. Transalar or transsphenoidal herniation. Herniation of brain matter occurs in and around the middle cranial fossa across the greater sphenoid wing. Compression of structures against the sphenoid bone causes symptoms. This form of herniation is not as common as other types of brain herniation. It commonly occurs with subfalcine and transtentorial herniation. There is a descending and ascending form. The descending transalar herniation results from a frontal lobe mass. Posterior and inferior displacement of the posterior aspect of the frontal lobe orbital surface over the sphenoid wing occurs, which may involve structures such as the orbital gyri and gyrus rectus. Compression of the middle cerebral artery within the sphenoid ridge can occur, resulting in cerebral infarction in the middle cerebral artery territory. Ascending transalar herniation is produced from a middle cranial fossa or temporal lobe mass lesion. The temporal lobe is displaced superiorly and anteriorly across the sphenoid ridge. Infarction within the territory of the anterior and middle cerebral arteries can occur due to the compression of the supraclinoid segment of the internal carotid artery against the anterior clinoid process. Differential diagnosis for brain herniation syndromes, post-traumatic subclinical seizures, acute hydrocephalus, tension pneumocephalus, electrolyte imbalances, meningitis, CSF overdrainage syndrome, osteopetrosis, Costello and posterior fossa crowding syndrome, etc. Investigations. Blood investigations includes urea and electrolytes, full blood count, liver function tests, serum glucose, serum osmolality, clotting, blood culture, and consider toxicology screen. CT and MRI brain. General findings includes general cerebral edema, midline shift, acute hydrocephalus, site and size of mass lesions, and cerebral infarction at the vascular territory of compressed vessels. The white cerebellar sign may be seen in global infarction. Specific findings for brain herniation syndromes is beyond the scope of this video discussion. Chest X-ray and echocardiography to identify sources of infection for cerebral abscesses if suspected, such as pneumonia and infective endocarditis. ICP pressure waveforms. Kindly refer to Part 1 of intracranial pressure for further details. Lumbar puncture should not be done if raised intracranial pressure is suspected, as coning may occur. Managing raised intracranial pressure. Follow the ATLS protocol. The mnemonic is DR, A, B, C, D, E. Neurological examination is done as part of the D or disability evaluation, which occurs immediately after airway, breathing, and circulation are addressed. Neurological assessment includes GCS score, pupillary function, level of consciousness, motor, sensory, and cranial nerve function. This is ideally done before analgesic, sedative, or paralytic agents are administered. Identify the clinical features as described previously. Confirm that the ICP waveform and reading is accurate if present. Consider differential diagnosis for altered mental status or obtundation, such as traumatic brain injury, impaired ventilation, insufficient oxygenation, hypoperfusion, hypoglycemia, medication and toxin overdose, etc. Therapeutic goals. Adequate cerebrovenous drainage, head up tilt 20 degrees, head in midline position, and measures to avoid raised central venous pressure. As CPP equals MAP minus ICP plus CVP, achieve adequate MAP for adequate cerebral perfusion pressure, maintain cerebral perfusion pressure at 60 to 70 mm mercury, MAP more than 90 mm mercury, avoid systolic blood pressure of less than 90 mmHg in patients with traumatic brain injury. Achieve this by optimizing fluid status and use of inotropes and vasopressors. Avoid colloids and hypotonic fluids in patients with traumatic brain injury. For central venous line insertion, femoral or subclavian CVL is preferred as the head-down position for IJV CVL insertion is avoided. Maintain ICP less than 15 mmHg or less than 20 cmH2O, PaO2 of more than 75 to 90 mmHg or 10 to 12 kPa. Avoid extreme hyperoxemia of more than 487 mm mercury. PaCO2 should be kept at 35 to 39 mmHg or 4.5 kPa. Avoid PaCO2 of less than 25 mm mercury as hypocapnia results in reduced cerebral perfusion pressure and risk cerebral ischemia in compromised brain regions. Avoid hypercapnia as well, as this increases cerebral blood flow, intracranial blood volume, and increases ICP. Regarding mechanical ventilation, insertion of an artificial airway is indicated in situations such as GCS of 8 or less, respiratory failure, inability to protect the airway, excessive agitation and aggression, etc. Oral endotracheal intubation is preferred over nasotracheal intubation as the latter can potentially increase ICP. Intubation and mechanical ventilation allows better control of PCO2. Volume control IPPV is preferred as it provides adequate minute ventilation to avoid hypercapnia. Blood glucose kept at 4 to 7 millimoles per liter. HB should be more than 7 grams per dl. Hematocrit more than 28%. Serum sodium 145 to 150 millimoles per liter. Serum osmolality 300 to 320 milliosmol per kg. Patient should be kept normothermic as hyperthermia increases cerebral metabolism and increases cerebral blood flow, and this must be avoided. Seizure prophylaxis with anti-epileptic drugs such as phenytoin, carbamazepine, pentobarbital, and valproate for the first 7 days after traumatic brain injury. Adequate sedation. Additionally, external ventricular drain should be considered if CSF drainage to lower ICP is desired. CSF drainage results in decreased CSF volume, decreased intracranial volume, and reduced ICP. During CSF drainage, the EVD cannot measure ICP, thus the EVD drain valve has to be clamped to measure ICP. To drain CSF using a EVD, place the CSF drainage valve at 0 mmHg and allow continuous drainage of CSF. Increase the pop-off level by 5 mm mercury per day. If the patient tolerates the valve set at 20 mmHg for more than 24 hours, a trial of ICP measurement, clamping, can be attempted with the intent to remove the EVD. Alternatively, keep the pop-off at 10 mmHg to allow CSF drainage whenever ICP exceeds 10 mmHg. Signs of intolerance of CSF drainage includes ICP more than 25 mmHg and neurological deterioration. The drainage valve needs to be lowered if this occurs. Assessment of autoregulation of cerebral blood flow can be done by increasing CPP by 10 to 20 mmHg, then measuring its impact on ICP. To assess the adequacy of cerebral perfusion, transcranial Doppler and jugular venous saturation can be used. EEG can be used to assess for seizures in case of unexpected surges in ICP. Thresholds for initiating ICP and cerebral perfusion pressure-guided therapies: ICP more than 22 mmHg or CPP less than 60 to 70 mmHg. However, do note that brain herniation has been reported with ICP of less than 20 mm mercury. If ICP is more than 20 mmHg irrespective of cerebral perfusion pressure, ensure adequate sedation and analgesia. Identify and treat sedation-induced hypotension as well. Adequate bed rest, quiet environment and minimal suction. Adequate minute ventilation and oxygenation. Identify and treat seizures. Maintain adequate cerebral perfusion pressure. Control MAP using fluids, vasopressors, and inotropes. Avoid hypotension and aim CPP of more than 60 mmHg. Reduce cerebral edema. Ensure adequate cerebral venous drainage by head-up tilt and head in midline position as mentioned previously. Measures to avoid increased central venous pressure includes avoiding head-down position, coughing, straining against a ventilator, such as due to blocked ETT, impeded venous drainage from the head and neck, for example by ETT ties, dressings, or tight cervical collar. Volume overload, avoid PEEP if possible. Avoid IJV CVL insertion in the dominant IJV. Increase plasma osmolality by increasing serum sodium concentration. Pharmacological creation of an osmotic gradient between the brain and the blood causes movement of water from the brain's intracellular or extracellular compartments to the vasculature, reducing cerebral edema and brain volume and ICP. This can be done with hypertonic saline or mannitol. Aim for serum sodium of up to 155 millimoles per liter, serum osmolality of 300 to 320 milliosmol per kg, and ICP of less than 20 to 25 mmHg. Hypertonic regimens examples includes IV 100 to 250 ml of 3 to 5% saline boluses given as needed to keep ICP below 20 to 25 mmHg. IVI 3% saline 1 ml per kg per hour. Note that saline that is 3% or more must be given via a CVL to avoid phlebitis. Hyperchloremic metabolic acidosis can be mitigated by a 50-50 mix of sodium chloride and sodium acetate. 30 to 60 ml boluses of IV 23.4% hypertonic saline is another option, administered via CVL over 10 to 15 minutes to avoid phlebitis and hypotension. Serum sodium should be monitored at least every 6 hourly. Avoid rapid decreases in serum sodium to prevent rebound cerebral edema, and avoid rapid increases in serum sodium of more than 10 millimoles per liter per day to avoid risk of central pontine myelinolysis. Hypertonic saline has a well-established role in the management of raised ICP, in brain injury, cerebral neoplasms, and in limiting secondary brain injury due to neurochemical changes. Advantages of hypertonic saline versus mannitol in decreasing ICP: there is a greater magnitude of ICP reduction, longer duration of action, and no rebound increase in ICP with hypertonic saline. Aim for negative fluid balance, for example negative 500 ml per day. A loop diuretic may be used, such as IV furosemide 10 to 20 mg boluses, or 0.25 up to 1 mg per kg. Osmotic diuretic, such as IV mannitol 20%, 0.25 to 1 gram per kg over 15 minutes can be used. This has a marked but transient effect. The effect is seen after 20 minutes and lasts for 2 to 6 hours. This may shift the patient down the intracranial compliance curve and gain sufficient time for definitive treatment before a catastrophic rise in ICP. Aim for a serum osmolality of 320 milliosmol per liter. Disadvantages of mannitol: if the blood-brain barrier is damaged, mannitol may cross into the brain parenchyma and cause a reverse osmotic effect. Mannitol is associated with rebound increase in ICP after 12 to 24 hours of use. Smaller doses of mannitol causes shorter periods of ICP reduction compared with higher doses of mannitol. Restrict fluid to less than 1.5 liters per day. Ensure the presence of a functioning urinary catheter to measure intake and output accurately. Regarding role of corticosteroids, corticosteroids reduces cerebral edema that surrounds tumors and abscesses, however has no role in head injury as it has no effect on raised ICP following trauma. Corticosteroids take several hours to work. In patients going for neurosurgery, IV dexamethasone 4 mg 6 hourly is often given electively preoperatively. Reduce PaCO2 to 4 kPa or 30 to 35 mmHg by increasing minute ventilation. This has a transient effect in reducing ICP. Reduced PCO2 results in reduced CBF, reduced cerebral blood volume, and reduced ICP. There is a risk of rebound hyperemia, where increased cerebral blood flow and ICP occurs. If hyperventilation lasts for 6 to 12 hours, metabolic compensation negates the effect of respiratory alkalosis. Excessive lowering of PaCO2 should be avoided to avoid cerebral ischemia and loss of autoregulation, thus avoid sustained PCO2 of less than 25 mmHg. Kindly refer to the video on cerebral blood flow for a discussion on the relationship between PaCO2 and cerebral blood flow. Induced pharmacological coma. Pharmacological coma results in reduced CMRO2, reduced CBF, reduced cerebral blood volume, and reduction in ICP. Therapeutic goals includes burst suppression on EEG monitoring and reduction in ICP. Agents used includes pentobarbital, thiopental, and propofol. For pentobarbital, low-dose regimen, IV loading dose of 5 mg per kg followed by IVI 1 to 3 mg per kg per hour. High-dose regimen for pentobarbital, IV loading dose of 10 mg per kg over 30 minutes followed by IVI 5 mg per kg per hour for 3 hours, then IVI 1 mg per kg per hour titrated to therapeutic targets. Thiopental has a shorter half-life than pentobarbital, 15 to 50 hours versus 6 to 15 hours. It is more suited for short-term therapy for raised ICP. The active metabolite of thiopental is pentobarbital, which accumulates with prolonged infusions. The dose is IV 3 to 5 mg per kg bolus followed by 3 to 5 mg per kg per hour infusion. Monitor and treat hypotension. Propofol. IV loading dose is 2 mg per kg, then titrate IVI dose to achieve therapeutic goals up to 100 to 150 mcg per kg per minute. Disadvantages of propofol includes hypotension, propofol infusion syndrome, which consists of renal failure, rhabdomyolysis, hyperkalemia, myocardial failure, metabolic acidosis, and death. Thus, avoid IVI propofol of more than 4 mg per kg per hour, especially if infusion lasts more than 48 hours. Research has shown a lack of improvement in outcomes when propofol is used to reduce ICP. Treat seizures with anti-epileptics. such as phenytoin, carbamazepine, pentobarbital, and valproate. Therapeutic hypothermia. Cool the patient to 34 degrees Celsius. Use muscle relaxants such as cis-atracurium to stop shivering. Reduced temperature results in decreased cerebral metabolism, decreased cerebral blood flow, decreased cerebral blood volume, and reduced ICP. Methods include skin-applied gel cooling systems, air circulating cooling blankets, surface ice packing, ice gastric lavage, etc. Be cautious of potential adverse effects of hypothermia, such as coagulopathy, acidosis, arrhythmias, and pancreatitis. Surgery. Exclude surgically treatable lesions and evacuate mass lesions. Consider brain imaging such as CT head. Decompressive craniectomy is an optional consideration for managing intractable increase in ICP. It is considered if the patient is less than 50 years old, GCS more than 3, and pupils are reactive. External ventricular or lumbar drain should be considered if CSF drainage to lower ICP is desired. Intermittent CSF drainage via an intraventricular catheter is effective in reducing ICP. However, continuous drainage can empty the ventricles completely, which will then make ICP monitoring impossible. Treat the underlying cause for raised ICP and treat exacerbating factors such as hyperglycemia and hyponatremia. If brain herniation is imminent, apply all measures as described above. Initiate the brain code. Elevate the head of the bed to 30 degrees with the patient's head in midline. Acute hyperventilation to a PCO2 of 30 to 35 mmHg. Administer mannitol or hypertonic saline. When ICP is controlled, stop intermittent muscle paralysis, return PaCO2 to 4.5 kPa, and check that all therapeutic targets are achieved. Anesthesia in the presence of raised ICP. Do not cause further rises in ICP. Achieve therapeutic aims as described above, and undertake all measures as described above if there is raised ICP, if applicable. Avoid increases in cerebral blood flow by avoiding hypercapnia, hypoxia, hypertension, hyperthermia, and anesthetic agents that increases cerebral blood flow such as ketamine, nitrous oxide, halotane, desflurane, and isoflurane. Kindly refer to the video on cerebral blood flow for further details. Maintain adequate cerebral perfusion pressure, avoid hypotension, aim cerebral perfusion pressure of more than 60 mmHg, control MAP using fluids and vasopressors or inotropes. Ensure mechanical ventilation provides normal PaCO2 and good oxygenation. Ensure adequate analgesia and adequate anesthetic depth. Avoid increases in central venous pressure using measures described above. Prevent further cerebral edema, fluid restriction while maintaining adequate intravascular volume and cerebral perfusion pressure. Avoid hypotonic solutions such as dextrose 5%. Fluid flux across the blood-brain barrier is determined primarily by plasma osmolality rather than oncotic pressure. This is the rationale for maintaining a high normal plasma osmolality. These are my references. Thank you.